It was very minimal.
Good. Well, you
Welcome
don't
to
need the details. We can expand in person.
That's it. Welcome to New York, Taylor Swift. We're not going to get sued. That's about all we're going to play there. All right. Before YouTube and copyrights us, I am joined by Abby, the Angelis, like Los Angeles.
Just I love it.
Just like it. And we go way back. We met in New York. That's why we're playing Welcome to New York. Are you are still, no, you're in Connecticut?
I'm in New Jersey now.
Jersey. I knew it was adjacent to New York, but yes.
Now it's just New York for fun visits.
There you go. Yes. And we are talking pelvic health PT. So catch us up. It's been a while since you and I even spoke. But I think the fans, the people want to hear about why women should know, and men as well. I think that's one that also doesn't get talked about enough. The pelvic health, what is it? What do you do? Who are you? Tell us what's going on, Abby.
I am a pelvic floor physical therapist for women. So yes, it's very important for men, but I focus my expertise specifically for women. And a lot of the time with prenatal, pregnant, and postnatal females. I met you as, 15 years ago, many years ago in a hip center. So I've combined my love of hips with pelvic floor and kind of put the two together so I can help my patients the best I can. And what is pelvic floor? Pelvic floor? Yes, it is essentially the cradle and the basis for holding us women, together. It keeps everything in place and everything working, and it's working 24 hours a day, no matter whether you're thinking about it or not.
So you're saying it's kind of important.
It's very important.
No way. I'll just share my quick perspective as a, because the male perspective is the only one that matters. No, we're being facetious for anybody listening. We're just joking around. But all seriousness, when I was in physical therapy school, I was like, oh, this seems pretty important, and it seems like it does some stuff. And it seems like that you described it. I've not heard it described that way. I like that. The cradle. Say it one more time. The cradle for all.
The cradle that holds everything together. Holds everything in place.
Perfect.
Because of the joy of childbirth, there's a hole down there. So these muscles keep everything in place.
Go figure. So yeah, I was like, this is pretty important at the time as a student. I was like, even though most OBGYNs are male, I was like, I don't think I should be in that setting because there's going to be lawsuits. And like, it's just not, as to my knowledge, and at least I'm in the state of Colorado now, there's at least one pelvic health physical therapist who is a male.
There were two in my first class that I took.
Yeah, and it's not impossible. And I don't know if I assume and my understanding is is it the Wallace and Herman is the big
Herman and Wallace? Yes, that's kind of the gold standard course. There's a few others, but that's the one that really is, you're getting the best information.
Right. So I spoke with a few people who went through that, and whether male or female, they're going through that and having to do internal mobilizations. Yes.
I mean, it's a little different now post-COVID, but you show up and it's 2 hours of lecture and then 2 hours of practice. Get down and dirty right from the start.
So yeah, that's a lot going on there. But again, now as a orthopedic clinical specialist that I am, sports orthopedics, anytime I see a male or female, more specifically a female, who's got hip issues, back issues, even down to the knee, sometimes the shoulder, I start bringing up this concept of like, hey, do you know what pelvic health PT is? And
amazing. The more we talk about it, the better.
That's why we're here. And yeah, I love spreading this message as much as possible. And again, it doesn't benefit my business per se. It doesn't benefit me, but at the same time, I'm like, this person needs more than I can do.
You're married, you have female friends, you have female colleagues. That's where it's important. It's important for everybody.
100%. So yeah, my thought though is, again, we're talking about, and most physical therapists, I think at this point, hopefully, or at least when people are presenting with some of this, are talking about the core. And for anyone listening, the core, and you could do a better job than me, but I think of it as the diaphragm at the top. So I talk about breathing first and foremost, and then the pelvic floor is that bottom of that core, and then there's the canister, transverse abdominis. We're trying to get things activated there, and then I think again,
it's all connected.
That's the magic. I want to hear more about that. So what do you do? Take us into a day in the life of an evaluation assessment of in the clinic there.
So as I said before, I combine my two loves, the hips and the pelvic floor. So I try to take it into probably a little more thorough and total body approach. You're looking immediately at posture, their spine, their back, how's it moving, their hip mobility. You're looking at strength inside and outside. So if you're not addressing outside, then, any work you do on the inside is kind of just halfway, and vice versa. So I'm definitely assessing their core strength immediately from the start, especially with my postpartum women, because there's diastasis recti, which is the splitting of the abs for those who don't know. And the abs are important because so much of people's understanding is essentially the bearing down, which is the opposite of, kind of what's healthy for a pelvic floor and keeping it in place day to day. Obviously, it's necessary for certain things, but using your abs is what keeps everything kind of connected and working properly. If a patient's having really tough time engaging their pelvic floor, you can have them engage their abs and it'll automatically kick in that pelvic floor kind of a little bit if needed. So it's like one of the good cheat muscles for the pelvic floor. There's a few bad ones, but those are the ones that if you're really struggling to make that connection, your mind-body connection, if you go with core breathing, deep belly breathing, it's really helpful.
I love that.
So, core. And then I do the internal evaluation.
Okay. We don't have to go into detail there. We don't want to be marked explicit. Let's go back real quick to diastasis recti. So the way it's measured.
It's not explicit.
Well, I'm just being a little facetious. Diastasis recti, real quick.
Yes.
Remind us how many fingers for anyone who's had a baby? Is it almost 100% of women will have some version of it, and then
no, not necessarily. I mean, Some people do. It's very common. I've had pregnant women come in I do second and third trimester. We typically take off the first trimester, but they'll come in, 4 months in with a 4-finger space. Okay.
That's a lot.
4 fingers, and they will be about to deliver with only 2 fingers. So all it is education, awareness, movement patterns that are, protective of your core and the baby, obviously. But it's really, there's no, hey, you have this many fingers, you definitely need surgery. When doctors say that, it's kind of a little bit frustrating.
Yeah.
But it's just any separation. And the harder to fix it are the ones that have the, children that are a little bit older. The sooner you address it, the easier it is to fix because the baby only gets heavier.
And speaking of that, in terms of, well, again, I any woman I see, like I said, in that area, hip, low back, I say, have you heard of a pelvic health physical therapist? Because that could be contributing. And I say, hey, it's like saying you have teeth and you've never been to the dentist. Like an OBGYN, and maybe you can educate us here on the difference between going to an OBGYN and going to a pelvic floor specialist.
So I like to say, I always ask permission first. That's usually a difference. Going to the OBGYN is quick in and out, generally uncomfortable. It's a little more just clinical. You have to establish a trust. And with coming to a pelvic floor therapist, it's definitely a gentler approach because patients are there for a reason, right? If they're there for pain, you're not going to kind of be more aggressive. So you're putting the patient in control with their permission, with their consent. And no matter what, it's no more than one glove finger that ever, does the assessment. And that's crucial because if someone's in pain, then you're not going to do something that, is going to make it worse for them. And then you're taking away that trust. It's a little more drapage, a little more comfortable environment. I try and keep it, a little calm and peaceful. It's just putting them in a more comfortable position and putting them a little more in control than when you go to the doctor's office.
Got it. And then again, coming back to make it all about me again, because this is mostly about me. Just kidding. But if I see someone again who's got a likely labral tear, they're positive Thatter and Thaber and all that stuff, hip pathology going on. How much would addressing the pelvic floor, and obviously it varies significantly, but I just want to get your perspective as kind of the other, like I'm referring out this way, again, almost every single time, no matter what, but what percentage? I'll tell women it might be 1% that this is going to help you. It might be 50% that this is going to help you, but I don't know, what being that hip background as well, how much do you find those play together?
So, I mean, I can't really give you a definitive percentage, but I do still see a lot of
we need the sound bite in podcasts. We need the sound bite.
If only it was an exact science.
I know.
As one of my professors used to say, it's all gray. The fact is, the hip rotators, which can be found externally and internally, are almost always affected when you have a hip pathology. So men and women, especially probably more males than females, when you have those hip labral tears, FAIs, etc., you do have referral pain to the groin region. So assessing it is really helpful. A lot of times, in the past, before I specifically jumped into pelvic floor treatment, I'd have these patients that were 95% better, and they still had that 5% of nagging pain. And I would send them then to my colleague for a pelvic floor evaluation. And it really was just those few muscles in the pelvic floor that, were just holding on and needed a little extra attention.
Gotcha. I'm actually thinking of a 15-year-old patient I have. And again, that gets into
male or female?
Female. And she's actually having bilateral, she has bilateral labral tears. She's going to have the right repaired later this month. And
Any
then
dysplasia?
Yes. so, and then the left one is, so she actually had a diagnostic injection in the right hip, very positive. So that confirmed that they're going to do that, but she hasn't had pain in her right hip since. She has the left hip going on. But my question here is, again, we have a minor, we have the parents' permission, is, that becomes a trickier topic in my opinion, versus talking to a 35-year-old female.
That's more education, and you can, dig in externally with the patient and the parents' permission. But for a 15-year-old, I probably wouldn't be doing a pelvic floor internal exam. I generally wait until they're 18, unless they're specifically coming in with consent, with parent permission at usually like 17, if it's, something different.
Is that just more, again, just like the age of consent type of thing, or is it more like the actual anatomy or anything like that?
Both. Just, when you're younger too, you're smaller, you're more petite, your body's still growing. You're not fully developed yet. Your muscles are still growing. Some people just are born tight, just in general. But also, it's a little more sensitive region for someone who's a little bit younger too.
Got it. Another one, I had another female pelvic health specialist on here a few episodes ago, maybe like 50 episodes ago. Actually, now it's all a blur after having the kiddo. But the question is, Kegels, yay or nay? I've seen a few differing opinions. I feel like this is the hot button topic here.
It so is. So when I left the hospital with my first, you get a big packet and it says, go home, do Kegels. Okay. I have a problem with that. So where's my problem? You just delivered a baby, whether it was C-section or vaginally. And no matter what, that's trauma to your body. So if you have a traumatized part of your body, you don't tell someone to go home and start exercising it. The fact is, there's inflammation, there's swelling. It can take weeks for your uterus alone to shrink back to its normal size. So telling someone to go home and do that, you may further traumatize it. So if you're exercising a muscle, you might be perpetuating, some of the pain that's there. One of the biggest analogies I like to kind of use with my patients is, everybody knows, where's the thing? Everybody knows their biceps, right? So you want to strengthen your biceps, you do bicep curls, right? So if you have a biceps, I'm trying to get the reverse.
Yeah.
That's this tight. This is all you have to work with, right? So if you're telling someone to go home and strengthen their pelvic floor with Kegels, that's this tight, you're just going to make it worse, right? So you need to be evaluated by a pelvic therapist before you just go home and start doing Kegels willy-nilly. Not to mention, half the time people don't have that mind-body connection with those muscles. It's not something that they're used to being like, turn on pelvic floor.
Yeah.
So I am a firm believer you see a pelvic PT before you just start doing Kegels.
Well, what is your recommended timeline then? Again, we saw pelvic PT before delivering the baby, and yeah, I don't want to share my wife's stuff. I don't. She hasn't given me consent, so but
Good.
I'm sure she wouldn't mind. But I'm gonna skip that. But the point is, we saw beforehand and after. So the term fourth trimester.
Yes, 6 weeks postpartum.
Right.
Generally, we like to have the doctor's consent, but the doctors don't always. It's not that they don't give consent; they just kind of don't focus on, the women's postpartum journey as much as offering the birth control.
Yeah, and
in Europe, it's a gold standard. 6 weeks after you have a baby, no matter what, you go to pelvic floor PT, whether you have pain or not, because you're preventing things from happening too.
So someone out here listening who's either having a baby or knows someone who's having a baby, a couple things too is this whole concept for some people, like I said, I was starting to say is when I start talking to a patient in front of me who's got hip or back pain, and I say, hey, do you know what pelvic health PT is? They're like, you mean like the OBGYN? And I'm like, well, sort of, yes, but it's a physical therapist who specializes. And I actually use that same bicep analogy that, again, if you're walking around like this, or you think of the big guy who has no range of motion and he's really stuck in that.
Yes.
And like, if that's how your tightness is, again, and someone puts a finger on there, it's like, oh, that hurts. You need someone to know what they're doing and put that finger on there to show you that, oh, that's really tight. And how do we start engaging that? That's the Kegels conversation. And would you agree with the Kegels, taking a step back, there is a place for them, but
100%.
Yeah. Okay. So because the last time we were just like, Kegels are evil, everyone stopped doing Kegels. But it was,
I mean, every muscle has a length tension relationship that, operates at that optimal, tension. But there's too much and there's too little. So it's important because you need the strength. Otherwise, everything falls out. It's holding all your organs in place too. So you don't want to end up with the extreme as well. So I'm definitely not anti-Kegel, but I think it should be with, control, guidance, and a professional. Just in the beginning.
Yeah. And I mean, I feel like that's the same thing for any fitness journey, personal training, more body. Again, somebody starting going to the gym, they can certainly go and do machines and they can survive, but they're probably not being very optimal with their overall training. And they might kind of flounder for 2-3 years, see some results and kind of manage their symptoms, so to speak. And then again, had they had someone who's a professional at fitness and understanding how the body actually works and how we should be doing exercise and what things they should be feeling, helping that mind body connection. That's that kind of higher level. And I would think it's worth a couple $100 up front. So, and that's another thing too. Most pelvic health PT is cash based, correct?
A lot of it is, or out of network based. Hospitals do offer, and a few rare clinics. You're just, limited by insurance guidelines and whatever plans are.
Yeah. And there's a reason, again, when people are avoiding insurance, paying as a provider, there's a reason that we don't want to be limited by the constraints of insurance. And we want to
get more time together, more quality time. You get to see the person as a whole. If a person comes in or a patient comes in and says, my back's hurting today, well, I'm not going to ignore that as an out-of-network provider. I can treat the whole person. That's the nice thing.
So speaking of treating the whole person, we were talking before starting live, my wife's book, which again, everyone should go get a copy. Yes. Support our kids' college fund.
100%.
But it's the Integrated Guide to Penetrative Disorders of Women. I might have thrown off one word there. But question being,
it's cultural influence too.
For sure. And the only the term vaginismus, which is, again, I'd be curious actually in your experience, how often are you seeing that? Because again, culturally, my wife starting her career in the Middle East, really, seemed to be a lot more prevalent there. That's where she really was motivated to provide some resources where, again, it's very taboo. People don't know where to
just don't talk about it. That's the thing.
Yeah.
Just talk about vaginas all the time.
That's right. I'm all for it. But yeah, in terms of the book and that concept, so yeah, what percentage
A
are you
lot.
seeing
Yeah.
vaginismus is
At
can
least
you
75%. They
whoa,
may even come in for another, problem or something bothering them, and it's something that they either knew they had or didn't know they had, or just thought it was the normal.
right.
There are a lot of things that are very common, but that doesn't mean that they're normal or you have to live with them.
That's a good sound, and I'm so it's reassuring to me again because it's all about me. Bone knows that this is the exact kind of language I'm using, so it really is great to hear that I'm saying the right stuff.
Yeah.
But yeah, that's so for anyone listening again, vaginismus. I threw that term out there. The way I describe it, and please correct me. And again, my wife is a specialist in this, so and wrote a book pretty much about this concept.
Mhm.
But it's where the
Yeah,
muscles
I
are
read
just yeah,
it.
but the muscles kind of just like shut down, and it can be painful for
It's not just shut down, they're just either
oh,
spasm, trigger points, they're just super tight or super irritated or inflamed or nervy.
mhm. Thank you.
It can be pain with penetration or internally too, and usually a combination thereof.
Mhm. And you also mentioned offline, and I wanted to bring this here is how often is that again a psychological referral out, mental health professional?
Yeah, how often I can't give you a percentage, but it's 100% helpful. Um, a lot of people hold tension in their pelvic floor, whether it's conscious or subconscious. And when you're constantly clenching a muscle, it can lead to pain.
Right,
Same thing for any muscles in our body.
right. And we see this a lot with like jaw tightness and grinding of the teeth as well, and just it's a stressful world, people.
Yes,
So
it is.
and people like to say like I hold my tension here in my upper traps, and again I always I've
So
been
many hold it in their pelvic floor.
right, and but again then it's easy to kind of bring to light, and not unless you have a physical therapist. I always joke at a party I can go up to anyone and just poke them on their upper trap, and they're either going to want to go home with me or they're going to punch me in the face. Could go either way. um so
Yes.
the point there is that again we're it's important I think to delineate where the muscles can be, and again this is something people it's exactly that concept, and I wish we could take that concept and again shout that one from the rooftops of again most of these things are very common, almost everyone has it.
Yes,
But you don't have to live with it.
exactly.
There's no easy answers, kind of like what you're talking about either.
And
There's
there's
like
no easy fix.
right.
There's other things if people aren't comfortable with doing internal work. There are things we can do externally, focusing on breathing and core and stretching all the muscles on the outside. But that internal portion really is, so crucial.
Yeah, and again, from an orthopedic physical perspective, again, I had a patient with kind of chronic low back stuff, some hip stuff, and then that's another thing. Again, orthopedically, where I'm sure you and I've been practicing at the exact same time since 2008. Was it? Was it?
Yeah.
Yes. Yeah.
I think
So
it was like weeks apart.
yeah, yeah. And the point being there that the go ahead.
We're old.
We're old. Yes, that's the point. Yes.
Lots of knowledge.
But no, but the point is, I think in our careers, we've seen so many folks who go through this hip, low back situation where they're starting to have some pain in their back. The hip stuff is kind of coming and going. And they're like, I got some clicking, and we're not really sure what it is. It's not the same as, again, having significant toothache or something like that, where it's like, well, we need to do something about that now. But I've seen that, back and forth so many times where it's like, well, the one doctor, the hip specialist thought, oh, well, maybe it's your back. And then they send them out to the back person, and the back person's like, well, maybe it's your hip. And then they keep going back and forth, and they're not sure what they want to operate on. And they're still not starting the whole
look at pelvic floor.
And they never look at, and that's the part too, where again, I'm going to do what I can to, if there's a person in front of me, hey, this is a thing that most people don't know about. It's not just an
It's all about the
OBGYN.
questions.
Right.
So, yeah, I mean, that's amazing for you, but if you don't know, maybe you dive a little deeper with the questions. So everybody knows, like, they're asking about the back, the hip, but maybe asking if, you're comfortable and confident, those more personal questions. Does it bother you when you're having sex? Are you sexually active?
Right.
Does it bother you when you're having sex? Do you have any trouble with going to the bathroom? Do you have any trouble keeping your urine in? All these, little bit of cluing questions without, cueing them.
Right.
That might give you a little bit bigger picture.
For sure. Yeah. And again, like I said, I end up getting, women above the age of 60 who have, again, this
I
kind
have a
of
92-year-old patient right now.
Yeah.
Never too late.
Right. And it's always a little, again, tricky. I'm this young, whatever, muscular guy. I got my biceps are stuck. And I've been told that's the feedback I get is like, he's a little intense. He's a little intense. But yeah, to be like, hey, this is a thing. You have back pain, you have hip pain, you're a 70-year-old woman. How many, and that was one other question I had before. I'm going to pull that one back. A little tangent is C-section versus vaginal delivery. How's that affecting pelvic floor? Is it just kind of, again, is there anything you think of when you hear C-section, let's say 2 C-sections, whatever, 10 years ago was the last one?
I mean, it's important. C-section, they're cutting through 7 layers of muscle, skin, tissue, all of the above. So, and you're not supposed to technically lift your kid for 6 weeks after. So that's really hard when you're either a new mom or a second, third time mom, and you've got others to lift and you're not supposed to, but they send you home with a baby and here you go. It's still trauma. It's a different kind of trauma. Sometimes it's incumbent because you're ending up with an emergency C-section when you've pushed for hours. So you've just traumatized the pelvic floor in that, and then you have to have a C-section. Or sometimes it's a planned C-section just based on your anatomy or whatever you and your doctor decided. But then also, you just carried a baby for, 10 months. So having that alone is also, impactful on all those muscles. So working on them is crucial. You're looking at both regardless.
Makes sense.
You just might have a little extra to do if they did have that C-section.
Gotcha. And again, from a global perspective, what I think of and what I do, you tell me if I'm off base here, and
Sure.
is C-section scar mobility, where
I always do it.
Yeah, and I discovered this very early in my career at Star Physical Therapy, where we met. Was I started seeing this connection of like, oh, you had a baby 6-7 years ago, you had a C-section, no one's talked about your scar. Let's see if we can do something about this scar.
It's never too late.
Yeah, and those nerve endings, that it's just like having rounded forward shoulders and bad posture. To me, orthopedically, I'm looking at it that way, and saying, yeah, let's loosen up this tissue. Let's reteach the body, and we can get into the pain science. And I'm sure,
scars aren't always at the surface too. That's what we have to remember. They're below the surface, especially with a C-section. As you're going through all those layers, it's probably a little more uncomfortable to work on a C-section scar than some of the other orthopedic scars. So we always have to be mindful of that. But otherwise, it's never too late, because if you're having any, adhesions or restrictions internally, it might be, connected to a muscle or something it's not supposed to. So by actually working on it, you might be giving them that mobility that they didn't know they were missing, or that was the missing link why they couldn't control their abs or activate them.
I love it. Do you still use the stabilizer for transverse abdominis activation?
No. I try to keep it as functional as possible of what they can do. It's all about touch. I'm in a private back room with my patients. So I try to do what they can do and replicate at home. So if they don't have that at home, I'm using, my hands. I'm giving them the cues of where they can put their hands to understand whether or not they're activating their muscles.
Gotcha. Yeah.
It's all about going back to basics. So many people come in and they're like, I'm squatting 200 pounds, or, they're power lifters, but they're leaking urine, or they have pain.
So you're saying leaking urine upon significant exertion is not normal?
No.
And we saw this. I was in the CrossFit space for a while. There was a whole kind of
have a lot of CrossFit patients.
Right. I do too.
It's a lot of bearing down. That's where I think it comes in.
Right. Double unders is a big one. Box jumps, again, those heavier deadlifts, or any of the Olympic lifts where, again, that heavier exertion,
the loading
seems to seems to not be connected through that. And I think this one is one that, again, we see at all ages. And we've seen it in competition where one of the youngest competitors, I still remember this was a big thing again in CrossFit. This was around 2014. The athlete, one of the top competitors, I think she was 20 years old. And yeah, she did like a PR lift in front of everybody and got it up. And it was like 300-pound deadlift or something. And yeah, there was just wet stuff going on the floor there. And everyone's like, what's going on? And so they tried to do a video where they talked about it, and they had even Rich Froning, who was like the famous kind of CrossFit guy. And he was like, I pee when I do double unders, and they tried to normalize it. And then there was a huge backlash from, so yeah, they were trying to normalize it, but it is that, again, it's common.
But it's not normal.
But it's not normal, and we need to have that conversation. And again, very few people want to do the work and sit in a room and pay, and again, like, it's going to vary significantly. I won't ask you that question again to put a number on it, but I imagine I always say, look, like, even one session, even if you have nothing going on, it's like, again, going to the dentist to get your teeth.
Education alone can be super helpful.
Right. Well, and the same thing with breathing. I'm always like, you're here for your neck pain or whatever. Like, how much should I tell you about breathing? Do we spend 10 minutes on that to really make sure you're getting the concept? Or do you feel like that's a waste of time as a patient? I feel as a clinician, it's super duper important. And again, the same thing when I start talking
tied to any exercise you do for the body, breathing.
Right.
You don't want to hold your breath. Otherwise you're going to bear down too.
Right.
You want oxygen to get to your muscles.
Right. And that becomes a thing though, is like, if we just introduce it, and we're not spending the time to make sure they actually get it right, is that like a waste of time? Because then it's not, they're like, yeah, I'm going to ignore that.
It might be productive
in
that sense. So, I mean, maybe you want to just set yourself up and plan for a few visits, the follow through.
Yeah. But again, I think we need to, if it's not clear, anyone listening who's made it this far in the podcast here, I think it's clear that we're advocating for anyone with a pelvic floor, which is males and females, should start thinking about finding a pelvic health specialist. Now, again, I end up having a whole resource list or specific folks where in different areas that I can say, hey, go check this out. Do you think at this point we're at a spot where you can just Google pelvic health PT in Central Jersey?
Your insurance companies typically will offer,
right.
offer recommendations. Doesn't always, you want someone who's a pelvic floor therapist.
Yeah.
Pelvic health, can be patient or PTs that only do external work, which is helpful, but you're still, missing that internal component. But you can Google her pelvic floor therapists that have taken the courses with them. You're registered with them, so you can search under there. That's, the gold standard. The APTA lists, I think probably the ones that use the APTA course.
Mm-hmm.
But yeah, Google's a good starting point. You'd be surprised how many there are, depending on where you live. But in New Jersey, we have them.
Yeah. And it's a bit of a catch-22 from my perspective of, these are folks just really trying. And again,
you just want to help people.
They just want to help people. But that's the thing. And the same thing in general with physical therapy. I think it's one of the biggest criticisms in physical therapy is we just want to help people. And therefore we're really bad at promoting ourselves and promoting this particular service. Like, again, that concept of fourth trimester is one that's just so like not talked about, where I don't know that we hope that, progressive hospitals and birthing centers will eventually just make that a part of standard practice. You mentioned in Europe, it's standard practice. It seems so ridiculous that, we have to be advocates for ourselves, but yeah, that's where we're going to keep trying to get these messages out. And
just regular physical therapists like yourself who don't specialize in pelvic health, but are educating, your clients. Hey, you're working with a male, but their wife's pregnant. Hey, tell your wife she should see a pelvic floor PT, right? It's very helpful in second and third trimester. It helps with making an easier delivery. Mm-hmm. Or getting prepared for delivery. And then you're telling them, look, 6 weeks after you have the baby, you're signing yourself for pelvic floor PT. We have direct access. You don't need to have a doctor's prescription. We generally like the blessing of the doctor, but it's not crucial. Some doctors just unfortunately don't care or understand it enough.
Yeah. That's great. Appreciate you sharing all that. I want to be respectful of your time, listeners' time. I think we covered a lot. Any other big takeaways you want to leave folks with in this grand concept?
It's generally fixable. Everything's common, but it's not normal.
Common, but not normal. Absolutely. Love that. And tell folks where they can find you.
I am Abby Angelis. So my company is Lotus Twin Physical Therapy. So www.lotustwinpt.com.
We'll have that in the show notes somewhere, somehow, left, right, up, down. I don't know. Somewhere, depending on the platform this is going on. But Abby, thank you so much for joining again.
Thank you for having me.
If you folks know someone out there who has a vagina, probably,
yes.
probably where, and again, like sometimes, I'm always like, I want to simplify it to that, but then you get into identification, binary, non-binary, and there's a lot to that, and so it becomes tricky.
But everybody has a pelvic floor.
Everyone has a pelvic floor, male, female, non-binary.
All of the above.
Yes. So yes, if you go to the bathroom, you probably have a pelvic floor. Let's probably. But yes, again, just like anything else, we hope to get that message out there. Hopefully this conversation got you 1% better, guys. Get this out to anyone special. So again, really important. The top people we want to get this to is folks who are ladies that are having babies, planning to have babies, had a baby. Even if you had a baby, again, like I said, 10, 20, 50 years ago.
Pain is not normal, even if you have pain.
What's not normal?
Pain is not normal.
Pain is not normal. There you go.
You can reach out to me too, even if you want help looking for a pelvic PT in your area too.
There you go. We'll leave it there. Thank you guys. And
thank you.
Thank you, Abby.